Good day everyone, I am here to talk about the renal diseases, but first we have to talk about the anatomy of kidneys. The kidneys are essentially regulatory organs which maintain the volume and composition of body fluid by filtration of the blood and selective reabsorption or secretion of filtered solutes. Kidneys take their blood supply directly from the aorta via the renal arteries. Blood is returned into the inferior vena cava via the renal veins. Urine is the filtered product containing waste materials and water. This is excreted from the kidneys, passes down to the fibromuscular ureters, and collects in the bladder. The bladder muscle is capable of distending to accept urine without increasing the pressure inside. This means that larger volumes can be collected, approximately 700 to 1000 ml. Without high pressure, damage to the renal system is occurring. When urine is passed, the urethral sphincter at the base of the bladder relaxes. The detrusor contracts and the urine is voided via the urethra. On sectioning, kidney has a pale outer region, which is the cortex, and a darker inner region, which is the medulla. The medulla is divided into 1 to 18 conical regions called the renal pyramids. The base of each pyramid starts as the corticomedullary border, and the apex ends in the renal papilla, which merges from the renal pelvis and then on to form the ureter. Nephrosclerosis, the first disease. This is the hardening of the walls of the small arteries and arterioles. Small arteries that convey blood from the arteries to even smaller capillaries of the kidney. There are two types of nephrosclerosis, the malignant and benign. So, benign nephrosclerosis refers to the renal changes most commonly occurring in association with long-standing hypertension. It is termed benign because it rarely progresses to clinically significant chronic kidney disease or kidney failure. Malignant nephrosclerosis, on the other hand, is where hypertensive nephrosclerosis occurs in presence of malignant hypertension. Vessel feature is intimal thickening, fibrinoid necrosis, red blood cell fragmentation, extravasation, thrombosis. These changes create an exaggerated layered appearance, or the onion skinning. Pathophysiology of nephrosclerosis starts with diabetes and hypertension. In diabetes, there will be an increased renal blood flow. Next is glomerular hyperfiltration. In hypertension, there is sodium retention. Next, there is an increase of tubular reabsorption that results to oxygen consumption. Next is tubular reabsorption and increased oxygen consumption, which results to tissue hypoxia. Tissue hypoxia results in decrease in nitric oxide, increase in reticular activating system, sufficient hypoxia inducible factors, activation, and decrease adenosine monophosphate activated protein kinase. Also, tubulointerstitial injury, microvascular rarefaction, and glomerulosclerosis. Clinical manifestations of nephrosclerosis are uremia, nausea, vomiting, fatigue, anorexia, weight loss, muscle cramps, pruritus, mental status changes, and visual disturbances. Diagnostic laboratory procedures, which are blood test, urine analysis, ultrasound of the kidneys, ECG, and renal biopsy. Medications such as ACE inhibitor, calcium channel blockers, angiotensin II receptor antagonist, renin inhibitors, alpha-1 blocker, alpha-2 adrenergic agonist, direct-acting vasodilator, and beta-adrenergic blocking agents. Nursing diagnosis for nephrosclerosis are decreased cardiac output, fluid volume excess related to decreased glomerular filtration rate and sodium retention, impaired urinary elimination, imbalanced nutrition, less than the body requirements. Next is the primary glomerular disease. A variety of disease including acute and chronic glomerulonephritis, rapidly progressive glomerulonephritis, and nephrotic syndrome can affect the glomerular capillaries. Acute glomerulonephritis is defined as the inflammation and subsequent damage of the glomeruli leading to hematuria, proteinuria, and azotemia. It may be caused by primary renal disease or systemic conditions. Chronic glomerulonephritis, one of kidney diseases characterized by long-term inflammation and scarring of the glomeruli. Clinical manifestations of the primary glomerular diseases are hematuria, edema, azotemia, and proteinuria. Pathophysiology of primary glomerular disease starts with antigen, group A beta hemolytic streptococcus, resulting to antigen antibody product, deposition of antigen antibody complex in glomerulus, increased production of epithelial cell lining in the glomerulus, leukocyte infiltrate the glomerulus, and then thickening of the glomerular filtration membrane, scarring and loss of glomerular filtration membrane, and then decreased glomerular filtration rate. Diagnostic laboratory procedures for primary glomerular diseases are blood test, urine analysis, step-to-zyme test, blood tissue culture, ultrasound of the kidneys, echocardiogram, CT scan, and renal biopsy. Medications are antimicrobials, vasodilators, loop diuretics, furosemide. Nursing diagnosis, fluid volume excess related to decreased glomerular filtration rate and sodium retention, impaired urinary elimination, risk for infection. Lastly is the polycystic disease. Polycystic kidney disease is an inherited disorder in which clusters of cysts develop primarily within your kidneys, causing your kidneys to enlarge and lose function over time. Cysts are non-cancerous, round sacs containing fluid. The cysts vary in size and they grow very large. Having many cysts or large cysts can damage your kidneys. Types of polycystic disease are the autosomal dominant polycystic kidney disease and the autosomal recessive polycystic kidney disease. Etiology, mutation, age, gender, mostly in males, early decrease in glomerular filtration rate, early onset of hypertension, high total kidney volume, early onset or repeated episodes of gross hematuria, women with hypertension, 3 or more pregnancies, proteinuria, microalbuminuria, and elevated serum copeptin levels. Overweight or obesity. So this is the formation of the cyst. First, mutation of polycystin 1 and 2 or fibrocystin of nephrocystins. Altered mechanosensation by tubular cilia. Then altered calcium flux that results to altered tubular epithelial growth and differentiations, resulting to abnormal extracellular matrix, cell proliferation, and fluid secretion, and then the cyst forms. Pathophysiology of polycystic disease. The cyst compression of renal vasculature, increase in renin, increase in angiotensin II. Increasing angiotensin II results to increase of growth factors, angiogenesis, endothelin increases, sympathetic activity increases, oxidant-mediated endothelial damage, increase in aldosterone, and increase in transforming growth factor beta. There will be cyst proliferation and expansion, systemic vascular resistance, sodium retention, and renal fibrosis. That results to hypertension and renal disease. Clinical manifestations for polycystic disease are high blood pressure, back or side pain, blood in your urine, a feeling of fullness in your abdomen, increased size of your abdomen due to enlarged kidneys, headaches, kidney stones, kidney failure, urinary tract or kidney infections. Diagnostic laboratory procedures for determining polycystic diseases are ultrasound, CT scan, and MRI. Medications: ACE inhibitors, angiotensin II receptor blockers, vasopressin antagonist, antibiotic, phosphate binders. Nursing diagnosis are decreased in cardiac output, fluid volume excess related to decreased glomerular filtration rate and sodium retention, impaired urinary elimination, imbalanced nutrition less than the body requirements. That's all, and thank you.